It's the weekend. I feel like he's the 2000s version of Timbaland. And it's called Blinding Lights. Good afternoon. Welcome to the Midday Exchange. It's 𝗠𝗲𝗱𝗆 doing the things. 16 minutes after 1. Welcome to Medical Mondays, powered by First Care Solutions. Today we're touching on a subject. We've had a number of messages and a number of responses, and a great, gigantic demand for a follow-up on patient safety. Dr. Steve Holt, good afternoon, sir.
Hello, Paul. How are you doing?
Like a new.
Yeah, good, thank you.
You're so formal on the mic.
I have to be.
Why?
It's my professionalism kicking in.
So we've had a really nice discussion a couple of weeks ago about patient safety, and there was quite a few questions that came through and said, you know what? Why not? Let's do it. Let's follow up.
Cool.
And you seem to enjoy it as well.
Absolutely. It's a bit of a passion. Patient safety and advocacy is something that is close to my heart. So I think it's an important topic.
Absolutely. Well, let's dive in. Looking ahead, how is the definition of clinical excellence evolving in South Africa and globally?
Paul, look, it's a complicated question because I think everyone has their own opinions on something like this. Patient safety is, or let's take a step back rather. So medical, legal, and the ramifications thereof are becoming a bigger and bigger thing in South Africa particularly.
Yes.
We're kind of following the US in that medical legal expenses are rising. The number of cases being brought against not only the private sector but the government sector as well are significant.
Okay.
And patient safety is something that needs to be taken seriously on every level.
Okay.
And I think as technology evolves and as we try and keep pace with the evolution of that change in technology, we're going to have to make sure that patient safety stays at the top of the list.
Of course.
And I think what's good is we now are able to analyze more, and I think the effect of AI in clinical practice is certainly going to make a difference as it in reference to patient safety.
We were talking a little bit about NHI last week. How does this sort of, I mean, these two obviously sort of will marry each other in the long term, right? Like you'll have to have good patient safety, good patient service. Meanwhile, it's not just about the private sector, but surely the public sector as well, right?
So I think the public sector is facing a huge challenge at the moment around patient safety, purely on the basis that the governance structures that exist are not necessarily carried through widely and consistently. And I'm not putting this on the public sector. It's a difficult thing to do in the private sector and the public sector. Okay. But I think policy and protocol is where safety starts. And once you've got those things in place, you then have to have the communication and the diligence applied to those policies and protocols to make sure that they affect patient safety.
Okay. When mistakes do happen, despite safeguards, what is the most important step in handling them transparently?
Yeah, that's a good one. So I think there's two sides to that. There's the patient side and there's the professional side.
Yes.
From the professional side, I think transparency is important. If there is a mess up, acknowledging that mess up and then being able to really make efforts to fix what has happened. And from the public side or the patient side, I think understanding the context of what that mistake is and whether it's material or not. You know, we'll get into communication and things like that, but the communication of a problem from the public side or the patient side of a problem and where they are concerned that an error has been made, it's very important that we assess the detail of that and whether in fact it was an error or whether it was an expected complication or a potential complication, and understanding the difference between an error or a mistake or negligence versus medical misadventure, for want of a better word, or whether in fact it is a recognized complication.
Yes, of course. I mean, from the I just want to touch on this again. The private and the public sector. You mentioned overlooking risks. How does something as simple as, for example, hand hygiene or communication breakdowns still cause such big problems today?
So I think, look, hand hygiene is important, and it's drilled into every medical professional day in and day out. But I think where the majority of issues arise is communication. And again, that's on both sides of the equation.
Yes.
If you talk about absolute communication, language, culture, those things become a real issue.
Yes.
In explaining a problem, in using cultural norms as to what a problem is. And on the other side, on the professional side, making sure that the person understands what it is you're talking about. You know, everyone always says, this doctor's got a great bedside manner. What they're really saying is that person communicates well and is trusted and explains well. And once you do that, there's much less space for medical errors.
I was actually having a conversation on Saturday with Dr. Voorman, and I was very sort of curious as to something as simple as bedside manner. I mean, I said, do they teach you this? Do they teach you this at med school? And they don't.
No.
And I mean, so how do you take care of something like, how does something like that, do you just develop a personality over time?
So I think everyone's got their own version of bedside manner, and that's why different people like different doctors, I think, because it talks to how they interpret things. So I'm not saying that people look for a doctor to find what they want to hear to some extent, but I think it's more about communication and how patients feel listened to.
Yes.
Because if you tell me something and I gloss it off, well, it's always like that, or it's never like that, or whatever, it means that the medical professional's not listening.
Yes.
And once you listen to what the person really wants out of the consultation, you very quickly pick up what you need to give that person to meet their expectation.
Of course.
And sometimes you can't meet the expectation, and in that case, the person doesn't get what they want from their visit. And under those circumstances, it's immediately a conflict because the person's not getting what they came there for.
Of course.
And that, I'm not talking about I want antibiotics. Well, do you understand why? Or do you understand the value of those antibiotics? It's more about saying, well, why do you want the antibiotics? And will it make a difference in your particular case? So that's where the communication, I think, is probably the single biggest factor that still gets in the way of safety.
Course. Yes. Culture is critical, right? But how do leaders, senior doctors, set the tone for safety for example, at a busy hospital?
Yeah. Safety, again, is protocol, policy, and that starts, with the doctors and their training and the nurses and their training, and making sure that they follow those policies and protocols, and that they understand them and know why they're in place. I think leading by example is the common feature. Certainly in my business, I try and lead by example. There's no point in saying, don't do that and then you go and do it.
Do as I do, don't do as I say.
Yeah, don't take shortcuts and then take shortcuts yourself. As a leader, you've got to make sure, and I suppose this applies to everything, you've got to follow the rules that you set, number one. And two, you've got to make sure that you are there explaining why those rules are in place. People will buy into rules and protocols and policies much better if they understand why they're in place and they can see that for themselves.
I guess, you're always going to have those people that Google symptoms before visiting. I can't imagine at any given stage that this helps. It does more harm than it does good. And what about that sort of in your experience?
So personally, I don't mind it. I think that, every single patient almost that I know has accessed Google at some point to look and see what they think. The problem with Google is the interpretation and where that information is coming from.
Yes.
So I think if patients are reasonable, there's no problem with them going to look up what they think they might have, and even suggesting that to doctors. I've had numerous cases where people have said to me, but what do you think about this? And it talks to being listened to.
Yes.
So you can say, yes, well, that's a great idea, and I can understand why you would think that or why you would have searched that. However, it may not be pertinent in this country. It may not be pertinent for where you've been. It may not be pertinent for the illness that you have. And these are the reasons why.
Of course.
So I don't actually see it as a problem. I think it's something that doctors have to get used to. And if you're open to that, it actually adds to the value of the conversation.
I think it makes you more personable, right? You go, yes, it could be this, but that's a really nice suggestion. But in this case, and then you've got a couple of follow-up questions.
Yeah.
And I think from a psychology point of view, being heard probably resolves like 80% of whatever's going on in your head.
Well, if you're getting the answers to the questions that you have, that is most of medicine. And that's why I think virtual healthcare actually still works as well as it does.
Absolutely.
Because there is so much information. I had an old professor, I'm not even sure if he's around still, but he always used to say that 80% of the consultation comes from the history and listening to what the person has to say.
I would agree.
And once you've got that information properly down pat, then the examination hugely adds value.
Yes.
But in many circumstances, you've got your answer long before
you know where you are.
The examination's been done.
And I suppose that breeds
it breeds trust.
I was about to say confidentiality. Training never really stops, right? How do you keep your team sharp, and what new technologies and treatments roll out so quickly?
So, Paul, I mean, with what's happening with digital and AI is presenting a real challenge, not only from the individual's perspective, but also the uptake, the understanding, the ability of the regulators to keep track of that. So what we try and do, we have something called a clinical excellence committee in our business, and that clinical excellence committee looks at new technologies. It looks to see what the literature is behind it, and whether or not that's been kind of approved or tested yet. We take that on board and we say, well, would this add value, in our opinion, to the business and to the patients? If we deem it to be safe, then we will implement it and look at a pilot study, and we'll roll it out in bits and pieces. But the challenge really is the rapidity of things that are coming available.
Yes, of course.
And people's baseline knowledge of digital tools. And just, I want to say computing, because how to use a computer. There's lots of doctors who don't know how to use Excel properly, or don't know how to use some of the basic tools. When it comes to new apps, new functionality, new ways of doing things, people have to have a base understanding of some of the tools in order to be able to use them properly.
Absolutely. We're going to have a quick music break. When we come back, we're going to be talking about technology and patient feedback. We'll be back on the other side of these. Don't go anywhere. It is Medical Monday. It's powered by First Care Solutions. We're with Dr. Holt. We'll chat to him just after this. It's Aha and Take On Me. First Care Solutions powers Medical Mondays every Monday at 1:15. Today we're chatting to Dr. Steve Holt. Chatting about patient safety. Dr. Holt, patient feedback can be sensitive. How do you make sure it actually leads to visible change and not just paperwork?
It certainly leads to paperwork. I have a couple of thoughts on this, and I think firstly, if you are a patient and you have a concern about anything, for goodness sake, don't go to social media. Okay, that doesn't help you. It doesn't help the anyone in the public, and it is not a good place to start your concern. I think, and this is a recommendation from me, but I think from the whole medical fraternity, if you have a concern, raise it. If you don't get joy from that, there are remedies to go to the Health Professions Council. There are other ways of doing it. But social media is just, it's too open.
It's very subjective.
It's so subjective. It's jumped on the bandwagon by people who don't understand the context of what was done, and particularly in emergency medicine, which is sort of my background. The social media adds no value to your complaint, and in fact, if you look at it from the professional side, all it does is kind of discredit your complaint in many respects.
Of course.
And once that has happened, the walls will go up, because from a medical legal perspective, there are all sorts of rules in place for professionals about how they answer, who they answer, and how they go about investigating things. So if you're going to complain about something, and by complaint I mean you may complain about the facility, the nursing, the doctoring, the diagnosis, whatever it may be, pick up the phone, drop an email, send a WhatsApp, but get in touch with your practitioner, and let's have the conversation. Let's try and solve it. Just putting it out there in the ether and social media really just puts up barriers and doesn't help anyone.
Is it that big of a thing that?
Yeah, absolutely. You know, again, so many of these things are contextual. You know, people will come in and they say, "Oh, you know, I waited 4 hours to see the doctor," and you say, "Okay, well, that's certainly not acceptable. Let us go and investigate." But once that goes on to social media, then everyone else, "Oh, I waited 3 hours. I waited 2 hours. I waited 1 hour." Okay, well, did you know what was happening? Did you know why you waited a long time? And in fact, when it comes back that you actually waited 45 minutes, not 4 hours, it kind of de-escalates things completely. But we don't want to get there. We want to say, well, why did you feel? We understand you had an emergency, but actually there were 4 emergencies before you. The doctor had a car crash on the way to work and was late, or you know, there are circumstances,
mitigating circumstances.
Correct.
Absolutely.
And it comes back to communication. If you have good communication, not only from the patient but from the medical provider, and in emergency units we find this all the time. I mean, that is probably our single biggest challenge, is waiting times. And
hence triage.
So triage is a tool aimed to sort of treat those in need first. But we need to, as medical professionals, communicate that to people so they understand. And no doctor goes out there to make you wait. Okay? No doctor goes out there to cause harm.
Of course.
I can tell you that much for free. But I do know that doctors sometimes, they're busy, they're focused on something else. They're not thinking about what the waiting room's doing. So good communication from the professional side needs to explain to people, look, go and have a cup of coffee. You know, there is stuff going on here. I can't tell you what it is, but there is stuff going down here. We're getting extra help on the way. Please be patient. Suddenly people are much happier to understand.
They're kept in the light. I mean, and as you said, I mean, anything could be happening. I mean, it could be an emergency, people saving lives. And on that sort of life-saving example, are there small everyday sort of wins in patient safety that go unnoticed, that make a huge difference?
Again, I think it depends on the individual practitioner and their ability to put policies and procedures in place. You know, in our business, we check every single X-ray. So when you get an X-ray in an emergency department, you go down the passage, you get your X-ray, you come back, the doctor says, yeah, it's broken, or I don't see anything. That then goes to be reported by the radiologists, and then maybe sometimes if it's late at night, that report only comes through the next day. And we go through and check every single one of those reports to make sure that it aligns with what the doctor says. You know, X-rays, as an example, are incredibly subtle. I mean, they can be incredibly obvious, you know, but they can be incredibly subtle as well. So putting in place a good policy to check X-rays and explaining to people, you know, look, I can't see anything. I can see your hand is completely swollen and you think it's broken. I have had a look on the X-ray. I can't see anything, but we'll get an opinion from the radiologist in the morning. And look, if it's not better, come back and we'll be able to have another look. Sometimes when the swelling goes down, you can see a subtle crack that you didn't see on the first X-ray. It's about communication. That's probably the single best tool that we have
Absolutely.
to mitigate those kinds of problems.
I mean, technology, like on the whole, we're not talking about stuff specifically, but technology on the whole, I mean, is amazing. But is there a danger of relying too much on the machines instead of sort of human judgment?
Look, I think as soon as humans stop thinking and rely solely on something technological, you're going to put yourself in a difficult spot.
Yes.
So the tech-enabled doctor is going to be better than the doctor on its own or the tech on its own.
Yes.
And I think that's where we're going. We like that blend of having tools, but still applying thought and judgment to those tools to make sure that the right thing is being done.
I mean, if a listener had just for example, if a listener had a medical experience about safety and sort of had a bad medical experience, what is the safest, most effective way to sort of help them raise their concerns?
So I think first and foremost, they need to get in touch with the provider that gave them the service.
Yes.
And explain to them what's happening and let the practitioner or the service deal with that problem. You may feel that everything about the service was terrible and you want a second opinion. It's always important, though, don't start from scratch again.
Yeah.
Get the information from that practitioner. Get your old x-rays, get your old blood results, those sorts of things before you get a second opinion. But if you... to my earlier point, don't just stick it on social media because you lose credibility as a patient. Secondly, go back to the practitioner that's caused the problem, speak to them about it, let them explain why they did what they did, and try and resolve the problem. Mistakes are made. Doctors and nurses are human.
Yes.
Mistakes are made and sometimes they're overlooked. But remember, that person wants to help you. And believe you me, as a doctor, if you do make a mistake, then your single biggest thing is now, oh hell, I need to fix this.
Yes.
So you're going to get in all likelihood, the best possible response out of that doctor or nurse to go back to them and say, guys, this was a problem. I didn't enjoy this, or you missed this. In emergency units, we have a big problem where people arrive, I have a fever. Boom, they dash to the hospital.
Yeah.
And then our doctor has a look at them and says, look, you do have a fever. I can't really find any origin for this.
Yes.
You've had the fever for 6 hours. What the doctor does wrong is they don't say, listen, this could evolve into an upper respiratory tract infection. It could be malaria. It's too early to test, or it's too this or too that. Let's not throw the book at you.
Yeah.
Let's review you in 24, 48 hours.
Sure.
In the meantime, take this and this and this. I think it's going to develop into that. What often happens is the person then goes the next day or 2 days later, because they're not better, to a general practitioner, and the general practitioner throws up their arms. Oh, gee, it's the most obvious tonsillitis I've ever seen.
Yeah.
If you had gone back to the place that you started, they would have seen the same tonsillitis that the GP saw, and I'm not having a go at the GPs. They would have seen the same problem.
Absolutely.
Had not had to repeat tests at additional cost and that sort of thing, and giving you the appropriate treatment. And this classic undifferentiated patient is a real challenge that we face in the emergency departments.
Just in closing, Dr. Holt, I mean, tech-enabled patient safety and clinical excellence, a doctor, versus somebody who, and you touched on this earlier, about somebody who doesn't have that tech available to them. I mean, is that an old breed that is sort of dying out, or just the doctors that are equipped technically just better doctors?
Again, I'd go back to the x-ray example. Before x-rays, what happened? The doctor said, I think your arm is broken, or I think there's a crack, or I think this, and we'll treat the symptoms and we'll put you in a cast in case. Now you have x-rays, you can see that nothing's broken, or you can see that something is broken, and so it gives you more information. Yeah. And I think that's where doctors have to get on board. You have to embrace new technology because it's better. It's delivering you more information. So clinical skills and acumen are still incredibly important. That gut feel that you get when you have a complicated case about, Is it this? Is it that?
Yeah.
That's what the tech is there to help you decide on. But you're the one making the decision.
Yes.
No tech holds accountability over you as the individual practitioner.
Got you. And just to end on this, Dr. Holt, obviously we've really pushed virtual health, and I mean this is cutting edge, right? I mean this is where we're going. If people want to try it out, if people are nervous to try out tech-enabled doctors, what would you say to them?
Well, tech-enabled healthcare comes in many formats. There's physical doctors who are tech-enabled, and there's virtual doctors that are tech-enabled. Virtual healthcare, in my opinion, is where most people should start with healthcare.
Agreed.
There's nothing wrong, even if you pick up the phone and say, look, I've got this and this and this. What do you think? I don't think we can help you virtually.
Yeah.
Why don't you go and do this there?
Yeah.
That's the right place to go, because the downstream costs, we have a lot of people that come to emergency units and I could have helped you over the phone. You wouldn't have needed to be there.
Yeah.
And vice versa. People phone in and we refer them in and they say, oh, but you didn't help us. What was the point?
Yeah.
The point is that in most instances, we can refer you more appropriately.
Yes, correct.
We can deal with primary things that don't need to be physically seen. And the doctors are well trained to make sure that they don't miss something that should be seen in person and something that shouldn't. And the tech is just getting better to help the virtual doctor more and more.
Dr. Holt, thank you so much. I know that we touched on the subject earlier, but I think for somebody who is in general nervous about are they going to have a good experience, I think you covered from good bedside manner, good tech, like it just the whole experience is just such a positive. From where I'm sitting, it just seems like such a positive experience.
Well, I think people need to understand what they get with virtual healthcare. And I think more and more people, we are seeing it in our own practice now, more and more people are using virtual healthcare as their first stop in the healthcare journey. It's not everything for everyone, but go and give it a try. Try out Care First and go and see what it's like.
What is the address?
www.𝗘𝗃𝗧.co.za.
Dr. Holt, thank you so much for your time. As always, it's a blessing. Thank you so much. I feel better, for one, because I know that this was important for me to, as somebody who needs surety.
Reassurance.
Reassurance, yes. You see, I need help with the words too. Dr. Holt, thank you so much for your time, and we'll chat to you soon again.
Pleasure, Paul. Great to be here.
Cheers.